to the
This
demo.
is really good. Can you make the diagnosis of a pericardial effusion from this tracing here? Well, that's what they did in the old days. Of course, it's possible, but it's much easier nowadays if you have two-dimensional echocardiography. Now, a pericardial effusion is defined as fluid around the heart. And in essence, one can see it with many views. And this is such an example, not in a human, but actually in a dog. So you see a pericardial effusion can be seen in other species as well. In this chapter, I would like to answer two questions. The first, is a pericardial effusion present in the first place? And if yes, does it really matter? Okay, are you ready for the first question? Well, one can make the diagnosis of pericardial effusion with other imaging modalities as well. We could, for example, use MRI, a chest X-ray, CT, or even the ECG, where one can see variations in the amplitude of the QRS complex, which is what we call so-called QRS complex alternance. But all of these methods have a few pitfalls. Either they're very expensive or not readily available, as for example CT or MRI, or they're rather inexact, as for example the chest X-ray, which is only able to detect rather large fluids, or the ECG, which is very unspecific as well. So the best choice definitely that you have is echocardiography. From which image position should you image a pericardial effusion? Well, my first choice would be the subcostal view. Why? Because we have a very good view to the heart and especially to the pleura in the region of the right ventricle. And this is where you frequently see pericardial effusions. This here would be now the diaphragma here. This is the pericardium, and right between the pericardium and the heart you have an echo-free space. Remember, that's the definition of a pericardial effusion. Here on the left you have the patient with the pericardial effusion, and on the right, after a few weeks, where the pericardial effusion was then gone. The subcostal view has an additional advantage. We're able to see the region of the right atrium, where we frequently see a pericardial effusion as well, and we can see the inferior vena cava, which will play an important role when we look at the hemodynamic sequels of a pericardial effusion. My second most favorite view is the peristernal window. Now, the peristernal window will show a pericardial effusion in the short axis view, for example, behind the left ventricle, or in front of the right ventricle, right here. And if you use a peristernal long axis view, one can see the pericardial effusion here as it extends more towards the apex, and right here as it also extends more towards the right atrium. So these views are ideal to look at the pericardial effusion, but we can also see them in the apical window. Here's an example of a four-chamber view with the pericardial effusion here in the region of the left ventricle, probably the right ventricle here, and the right atrium. Now, it might be very easy to see a large pericardial effusion, but it can sometimes be quite difficult to see a small pericardial effusion. So you have to know where to look for it. I already showed you one typical area where you should be searching for an effusion, which is the region of the right atrium, right here. But another region is lateral to the right ventricle. And to see the pericardial effusion here, you need to use a little bit of an atypical view in the sense that you move the transducer more to the right and sometimes slant the transducer so that the septum is a little bit more slanted toward the left. So here would be the pericardial effusion neighboring the right ventricle, which you don't see as nicely here in a normal standard four-chamber view. Most pericardial effusions are circumferential, especially if they're at least moderate or large in size. But sometimes you will see localized effusions as well. For example, as mentioned, you can have them just right behind the left atrium, the right atrium, or sometimes only behind the left ventricle. The reason for having localized effusions is listed right here. Frequently it's post-traumatic or trauma, which means there is some kind of a bleeding, or you have an infection. In this case, the pericardial effusion is somewhat chambered so that there is no free communication with the fluid throughout the entire pericardium. That's why they're localized. Let's take a look at this patient. This patient was sent to ablation therapy because he had atrial fibrillation, and when he came back, he complained of chest pain and dyspnea. This is the echocardiogram of the patient. Now, not a good finding. Why? Because we have a localized pericardial effusion right here. In addition, fibrous strands, you will hear later why this is important, and obviously this indicates some form of bleeding, probably as a result of the ablation therapy. So what is the key message here? You have to watch out because sometimes pericardial effusions are hidden and you have to search for them, just as for the spider here, which is hidden within the white flowers. And you have to watch out that you don't mistake something for a pericardial effusion. For example, this patient here, where one thought that there is a pericardial effusion right here in the region of the liver, which in essence is what we call epicardial fat. What is epicardial fat? Well, it's a normal feature of the heart. Every heart has some degree of fat attached to it on the epicardium, especially in certain regions. And this can look very similar actually to a pericardial effusion because it too can appear as an echo-free space. This is a beautiful example here where you see both a pericardial effusion and epicardial fat. Now, if you have some degree of fluid surrounding the heart, you can see the epicardial fat much better, and this sometimes leads to the differential diagnosis or to the confusion that this might be some kind of a structure on the heart, a tumor, or maybe some infectious material, which in essence it is not. So beware that epicardial fat can be confused with a pericardial effusion. The regions where you see the epicardial fat very frequently is right here in the groove between the atria and the ventricle, and very frequently you would see it here at the bottom of the heart and sometimes frequently also located close to the left atrial appendage. One feature of epicardial fat is that you don't see very much of it in the region of the atria. So if you have a structure there, very likely it is not epicardial fat, but something else. Subcostal view, echo-free space behind the heart. Is this a pericardial effusion? Well, no. This is another differential diagnosis you have to know. This is ascites. The patient has water in the abdomen, free fluid, which is seen right here. The pericardium would be here, and you do not see a space in between. Now, it might be difficult at times, but if you move the transducer to other parts of the body, for example, to the abdomen, you will see that there truly is free fluid here. But you can also focus more on the liver or on the spleen, and then you will see that actually the fluid is in the abdomen and not surrounding the heart. What about this example here? Again, we have an echo-free space behind the posterolateral wall and here behind the left ventricle. Is this a pericardial effusion? Again, not. This is a pleural effusion. In this chapter, we'll hear much more about the pleural effusion towards the end. But one thing that I want to mention here right at this point in the lecture is that the pericardial effusion would be free fluid that is in front of the aorta, while a pleural effusion always reaches out or extends behind the aorta. So this is the classic criteria how to differentiate the two. At this point, I can tell you that this is nice if you only focus on a peristernal long axis view, but you're free to put the transducer anywhere on the body. So if you put the transducer in the back, you can easily differentiate the two from each other anyway. But this is nice. This is what you should learn, and that's what's in the textbooks. Are you ready for the second question? Does a pericardial effusion matter? Here we have three issues: the cause, the size, and the question whether or not tamponade or some form of hemodynamic compromise of the pericardial effusion is present. Let's look at the cause, and you have to figure out whether or not the pericardial effusion matters or not. Here is the first example. A young individual with myocarditis was sent to myocardial biopsy, and this is the echocardiogram that was performed afterwards. We see free fluid here, and obviously it matters because here we have the suspicion that something went wrong during biopsy and that we perforated the heart and that this might even be blood. Of course it matters. What about this example? Well, very dramatic finding indeed. Again, a patient who underwent a procedure in the cath lab, and here we see this ugly pericardial effusion here where you can actually see the starting to coagulate blood in the pericardial sac. So this is a hematopericardi. No question. This is something where you really have to be quick in relieving the pressure inside the pericardium. Another example of a hematoma, this patient underwent a cardiovascular surgery. He was operated on the tricuspid valve. He was an HIV positive patient and had tricuspid valve repair following endocarditis. And 2 days after the operation, he suffered from dyspnea, and this was the finding we have. Now, this is a more consolidated form of a hematoma. We have a large hematoma here inside the pericardial sac, and this obviously also matters. It might not be such an urgent situation as we had in the previous case, but this patient definitely needs reoperation. What about this patient? Dialysis patient. Routine finding of a pericardial effusion right here, and right here. Does it matter? Not really, because we know that many patients with dialysis patients have pericardial effusions. And the same is true for this patient with amyloidosis, an infiltrative disease where we frequently see both pericardial and pleural effusions. Again, a circumferential pericardial effusion right here, here, and here. Certainly there is no hemodynamic compromise here. The patient is stable, so we do not need to matter. It's just an incidental or actually a complementary finding of amyloidosis. Things might look a little bit different in this patient here with myocarditis. Why? Because, first of all, this pericardial effusion together with the reduced left ventricular function points to the diagnosis of myocarditis, so it can be used in a diagnostic sense. But it certainly does not need any form of relievement. We do not need to perform pericardial tap here. It's again just a finding which is complementary to the disease of myocarditis or infection of the heart. So nothing to worry about, but an important finding in the sense of helping us with the diagnosis. What does this case have in common with the previous case? Both have an infection of the heart. Only in this case we have involvement of the pericardium in what we call pericarditis, and probably in a bacterial infection because we have organized structures within the pericardial sac. And here it would matter because these patients can develop what we call seroeffusive constrictive pericarditis. And such patients are always at risk of developing classic constrictive pericarditis even after infection was alleviated or healed. So again, an important finding that leads to the diagnosis and must, of course, be followed up. And what about this patient? Well, a sad story. Again, a rather young male patient with malignancy. He had melanomas and he had secondary tumors also in the heart itself. You can see them here in the right ventricle. Look at this irregular contour of the left ventricle here, probably also in the left ventricle. And as a consequence, he has a so-called malignant pericardial effusion. Such pericardial effusions can get quite large and can cause hemodynamic compromise. Now, of course, you will have to look at the clinical situation the patient is in, but if he does develop symptoms, you will have to tap this patient. So especially in oncology patients with a pericardial effusion, you have to watch out. Now, you might not always see the tumors in the heart itself. Sometimes they're in the pericardium and very difficult to visualize, if not invisible at all. And the only thing you will see is a pericardial effusion. Here is such an example. Also a patient with a lymphoma. You don't see any tumors in the heart. You only see the large pericardial effusion surrounding the left ventricle. My suggestion, follow these patients up and look closely at their symptoms. And if they develop symptoms, you will have to react. Here's a list of potential causes of pericardial effusion. Just to make things short, what is important for you? Watch out for those who are now pinpointed in red. Those are the causes where you have to watch out. If there's some form of infection, if you have malignancies, if the patient had a trauma, and especially in post-cardiovascular surgery patients or patients who underwent some form of a procedure. Of course, you will frequently need a thorough workup to figure out why a patient has a pericardial effusion. In many cases, you will still not find the definite answer. We call these idiopathic pericardial effusions. But by looking at the echocardiogram, you can get at least some hint as to what the cause of the effusion could be, especially if you can pinpoint the pericardial effusion as being a transudate, where you have a very clear fluid within the pericardial sac, an exudate, where maybe fiber strands are present, a PU pericardium where you have consolidated parts, as we saw previously in the patient with the pericarditis, or a hematopericardium where I showed you an example as well. So you see, knowing what the cause of the pericardial effusion is definitely helps you to decide whether or not a pericardial effusion matters or not. Now we'll go to a second important point, namely, how large is the pericardial effusion? You probably noticed from the examples I showed you so far that there is a fairly large variation in the size of pericardial effusions. Well, normally you have at least some degree of fluid within the pericardial sac. That's important so that both parts of the pericardium can kind of glide between each other, but the fluid never exceeds more than maybe 15 to 20 milliliters. If you have more fluid, then we would have an echo-free space in diastole. And this is the actual definition of a pericardial effusion. And that's also where we measure the pericardial effusion. And this scale I have here on the screen shows you how to grade pericardial effusions according to the societies here on the right. And this is my little, I would say, suggestion to you, because the difference between these two grading scales is simply that we also define very, very small pericardial effusions as minimal and pericardial effusions which are huge as a swinging heart. So take a look at these different degrees of pericardial effusion, and here would be the corresponding amount of fluid that you can estimate to be in the pericardial sac. However, be aware that there are sometimes variations in the measurements depending on where you measure, if it's, for example, the reach of the lateral wall or behind the left ventricle, and that, of course, the pericardial effusion can be localized. So when you put these measurements into a report, always say where you measured. I guess you all agree that this is an example of a patient who only has a minimal effusion. Where would you measure? Well, probably right here. And then you would say, okay, small or minimal pericardial effusion in the region of the left atrium. What about this patient here? This is also a relatively small effusion, located, however, around the entire heart, so circumferential. That's what we would call small. This effusion is slightly larger, especially if you look at it from a subcostal view. This would be probably a moderate, maybe even moderate to large pericardial effusion. So you can see not only we do measure an effusion, but we also eyeball it. This, in turn, would be a very, very large pericardial effusion. He could probably have more than a liter of fluid within the pericardial sac. And in such situations, the heart would make a kind of a swinging motion within this pericardial sac. That's what we call it, swinging heart. Here's an example for you. A patient comes in with rheumatoid arthritis. We perform an echocardiogram, and this is what we find. Something to worry about? Definitely not. The patient only has a small pericardial effusion, and rheumatoid arthritis very rarely causes large pericardial effusions, which cause tamponade. They develop slowly, therefore the pericardium has time to adapt, and therefore the hemodynamic sequels of such an effusion are rarely significant. One last tip when it comes to quantifying pericardial effusions. I showed you that it's possible to measure, but it's probably better if you compare the patient from one exam to the next. This is an example of such a patient where you nicely see the regression of the pericardial effusion. If you always take exactly the same loop and put them on one screen, you will see that the pericardial effusion was probably moderate here. Then it got a little bit larger, smaller again, and then at the end, it's almost gone. This is, for me, the best evidence that the therapeutic effect of whatever was done in this patient was effective or not. The last issue we have to look into is whether or not the patient has tamponade. Now, tamponade, in essence, is a severe clinical condition, and patients who have tamponade have to be symptomatic in one way or other. So expect to see symptoms of either hypotension, dyspnea, tachycardia, or edema, or maybe all of them together. Tamponade is on the far side of hemodynamic compromise. You might have more subtle forms of hemodynamic importance of pericardial effusion, and these you can detect with echocardiography as well. The example I'm showing you right here is that of right atrial inversion, which is a subtle form of hemodynamic compromise. You see that both in the subcostal view and in the four-chamber view. This patient has a more progressed form now. Here we not only have inversion of the right atrial wall, but also of the left atrial wall. Still nothing to worry about if the patient is asymptomatic. And finally, in this patient, you will have to worry because now we have compression of the right ventricle. And patients usually develop symptoms in this setting. Again, a patient where the right ventricle was perforated during implantation of a pacemaker. In all of these settings, what you should be looking for is the IVC, because if you have a dilated IVC, this somehow speaks for hemodynamic significance of the pericardial effusion. So follow the IVC as well and take that into your assessment of patients with pericardial effusions. And one last topic, if you have a very, very large pericardial effusion, as the swinging heart that I showed you previously, most likely the patients will have at least some degree of dyspnea or some symptoms. Not necessarily tamponade, but they will be symptomatic. And frequently you will have to act, especially if an effusion that is as large as this one here. And finally, you do not need to be a rocket scientist to know that you have to act in this situation, the patient that has bleeding into the pericardial sac. The role of echocardiography here is simply to document that blood is in there. And once you have that, rush to the OR. So you see, the topic of pericardial effusion is a quite simple one. Of course, there are more complex issues as well. For example, looking at the inflow signal of the mitral valve to look at all sorts of different things. But this is something we'll teach you in the masterclass. Why are we covering pleural effusion in an echo course? Simple. Pleural effusions are frequently present in cardiac conditions, and pleural effusions can mimic symptoms of cardiac disease. And I think it should be an integral part of every echo exam that we look for pericardial effusion and that we detect the pericardial effusion if it is present on our echocardiogram. Take a look at this example. This patient definitely has a right heart problem. His left ventricle is pretty okay, but there is massive tricuspid regurgitation. You can see that there is tricuspid regurgitation and that right ventricular function is poor. Now, if we look at the pleura of this patient, no wonder the patient has not only pleural effusion right here, but also some degree of ascites. The reason is that right heart failure is frequently associated with pleural effusions. So, especially in these cases, you should look for it. And how do we image a pleural effusion? Well, I would prefer to use a longitudinal view where you put the transducer either on the side or on the back of the patient. In this case, we have the free fluid here. This is top, this is bottom, and what you nicely see here is the spine. That is also why we call it the spine sign. The fluid in front of the spine permits us to see the spine, and not only that, but also the aorta right here. If you want to visualize the pleural effusion on the left, you can do that as well. Here we have the example I showed you previously with the diaphragma here. Now top is here, bottom is here, and this is the pleural effusion here, and this is the free fluid in the abdomen, the ascites. Of course, you could even detect small amounts of pleural effusion. This is the advantage of echocardiography. We're actually more sensitive than the chest X-ray is. A very small effusion right here on top of the diaphragma. Okay? And we showed you this image previously, or a similar image. How do we differentiate a pleural effusion from a pericardial effusion? In the peristernal view, very simple. You have the aorta here. This small little free space here is the pericardial effusion, and everything that is behind the aorta is the pleural effusion. What about the apical views? If you see an echo-free space close to the right ventricle and the right atrium, that would mean you have a right-sided pleural effusion. To see this, you have to, of course, extend the depth so that you penetrate deep enough to see the pleural effusion. Vice versa, if you want to see a pleural effusion on the left, you just focus more towards the left ventricle. This is here now the pleural effusion, the pericardium, and here is the pericardial effusion. The patient has both. Again, we have fibrous strands here in the pleural effusion, which points to an infectious origin, and that was actually what the patient had. My question to you, from where was this image obtained? It's not a subcostal view because we have the left ventricle here in front and the right ventricle here in the back. This obviously was imaged from the back. Because the patient has a pleural effusion, we're even able to see the heart. The free fluid, the atelectatic lung, which is collapsed due to the fluid. This is the pericardium, and this is the left ventricle. So you can see we can be very creative if we have a pleural effusion. And sometimes this is quite helpful in patients who are not easy to image from any other position. Pleural effusions are visible in a transesophageal echo as well. You'll see that later. Here's a large pleural effusion we see from a TE. It's also possible to visualize pleural effusions with transesophageal echocardiography, but that is a specific topic we'll discuss in the part on transesophageal echo. To summarize, when should you be looking for a pleural effusion? First of all, if you have right heart disease or a problem with the right ventricle, if you have unexplained dyspnea, because maybe the effusion is actually the cause of dyspnea, not a cardiac problem, if the patient has fever, and finally, malignancies. Patient comes to screen for left ventricle function in chemotherapy, and you image the pleural and maybe find pleural or pulmonary involvement. What do I mean? Here's an example. Patient with pancreatic cancer, and what we found was pleural carcinosis. Again, the structure, the echodense structure here in the lung is caused by the tumor of the patient. So you see, detecting pericardial and pleural effusion is quite simple in echocardiography. Still, as I showed you in this lecture, be cautious that you don't diagnose something which is not a pericardial effusion, and always keep in the back of your mind whether or not the pericardial and pleural effusion is relevant for the patient.